Welcome, and thank you for joining us today. The American Society of Transplantation is proud to present today's webinar on Applications of AI to Heart Transplantation. This webinar is part of a series of educational offerings on the applications of AI to transplant, developed by AST's Transplant Administration and Quality Management COP and Thoracic and Critical Care COP. In a moment, I will turn the session over to our moderator, AST President-elect Dr. John Kobashigawa from Cedars Sinai Medical Center in Los Angeles, California. However, before we begin the main presentation, we do have a few housekeeping notes to help you engage with today's session. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. This webinar is being recorded, and the archive will be available on the AST YouTube channel in 2 to 3 business days after the live session. Please note that all of your lines have been muted for the recording so that the presenters can be heard clearly. If you have any questions for our panelists during the Journal Club or the webinar, we encourage you to participate using the Q&A button in the Zoom webinar panel. Questions submitted via the chat window may be missed during the presentation. Finally, when you log off at the conclusion of today's webinar, you will see a link to a short evaluation survey to complete. Please fill out the survey to help us keep our content current and engaging. I now turn the session over to our moderator, Dr. John Kobashigawa, to begin our presentation.
Well, thank you so much, Brian. It's certainly an honor and privilege to be moderating this session on artificial intelligence and transplantation. Let me tell you a little bit about our speaker. I think you'll enjoy hearing about this as well. So Rohan Goswami is an advanced heart failure and transplant cardiologist in the Transplant Center at Mayo Clinic in Jacksonville, Florida. He received his medical degree from the American University of the Caribbean School of Medicine, St. Martin, Netherlands Antilles, and went on to complete an internal medicine residency at the Stanford Hospital, Columbia University College of Physicians and Surgeons in Stamford, Connecticut, where he was also chief resident. During his time at Stanford Hospital, he developed and implemented a resident education system to help improve resident knowledge, patient care, and patient outcomes. He then completed a fellowship in cardiovascular diseases at the University of Tennessee Health Science Center in Memphis, Tennessee, and his advanced heart failure and transplant cardiology fellowship at the Mayo Clinic College of Medicine in Jacksonville. Dr. Goswami has a background in information technology and is focused on innovation and clinical research. And just in speaking with Dr. Goswami, he told me that he started his AI development back at age 11 when he was involved in Pokemon cards and actually developed some program in order to sell these cards and made quite a bit of money starting at a very young age, I might add. Not only that, he also tells me that in order to finance his medical school, he sold softwares and actually came up with something very interesting called Chat Santa Claus. Well, you might imagine. I think that went over extremely well. No doubt he financed his medical school quite well during that period of time. Just to give you an idea of what he has done and where he has been. And also as a note, I just found out that he's an avid mountaineer and climbed Mount Kilimanjaro with his father in 2016. Well, with that all in mind, let me not waste any further time and present Dr. Goswami. Please welcome to the ASC webinar series.
Thank you so much, Dr. Kobashigawa, for that introduction. It takes me back a few years, but looking forward to the talk today and discussing applications of AI and heart transplant with our audience. I think it's an interesting time to be talking about AI. There's a lot of discussion about it in the world of medicine, and so let's jump right in. So here's our conflict of interest disclosures. And so as a brief outline for everybody that's going to be viewing this, I think it's important that we talk about the basics of AI principles, try to get everybody on a level playing field and really understand how we can use AI to our advantage. The majority of the talk will focus on AI and heart transplantation, pre-transplant, post-transplant, and some on donor management. And then we'll talk a little bit about how we as physicians and as providers need to evolve and really understand how we can implement this in our practice and look to where the future is taking us. And then we'll have some time for question and answer at the end. So the objectives for the viewers, I really hope that by watching this webinar and being able to understand the content that we discussed today, you'll understand AI framework to some basic level. You'll be able to understand kind of the research that I've done and the research that the field is doing in AI and how it applies to heart transplantation. And then also maybe build some confidence and get rid of some of those people that are worried about Skynet in the background, and how that's going to work with practice in the future, both on the patient side and on the provider side. And so I always like to start everything off with a little bit of a joke to set the stage. So I thought this was a pretty funny cartoon depicting a physician seeing a person in the emergency room saying, "Your X-ray showed a broken rib, but we fixed it with Photoshop." So maybe that's something in the future. I don't know. So kind of just setting the stage from a historical standpoint, AI is not something that's new. Artificial intelligence, kind of as a concept, started in the 50s and has evolved through the years and has come to where we are today and where we think about ChatGPT and even your Netflix queue and things like that. But the first real attempts for artificial intelligence were in radiology, using radiology to kind of understand how we can apply something that's already software built as far as radiographs and ultrasound images, and really understand, can we classify disease processes? Can we identify high risk features that maybe somebody at 2 in the morning who's taking call would miss, and try to improve care. When we think about the underlying process of what artificial intelligence does, there's two ways of AI to work. One is where you put it in a black box, it learns from itself, and that's called unsupervised learning. The other process is where you train the artificial intelligence, give it some information and say, this is a picture of a dog or this is a picture of a femur, and it learns from that, and then it's able to apply that algorithm to other images which are not labeled. The current iteration of AI that we're all familiar with and heard about in social media and in news is really focusing on kind of this interactive AI or generative AI, where it's able to generate either content or thoughts or discussion based on what it's learned from its training library. And that's where deep learning or machine learning kind of comes into play. The future of AI, as we look at it both in medicine as well as in the world, is really cognitive computing, looking at how we can create smart systems that are in either a silo and provide us information, or are able to interact with the world and give us new opportunities of interacting with the world and each other. And so when we think about just the basics, in general, most AI is really fancy statistics that's modeled in a way that we haven't thought about before. In actuality, the definition of artificial intelligence sits with how we can augment human tasks. So for medicine, it's you can consider sorting and screening. This includes large language models. So anybody that uses Dragon dictation or Control F to find something in the medical record, that's using some part of AI to find language context in your documentation. We've all trained our little microphones to understand our accents and how we speak and at the pace we do that. And as they learn and adapt, that's also some small application of AI, especially with some of the newer software. And then from a medical record standpoint, as we think about how it augments our tasks, we have these best practice alerts, these, hey, you need to put a defibrillator in somebody, or this patient's not on an ACE inhibitor. And to most degree, that's just a checkbox that the system is looking for. But it's a task that's being automated and nobody has to do that. And so at some level, that's all kind of an artificial intelligence platform. One of the things that we look for in the future is how can we change this kind of task-based method to more of a self-learning, a self-contained, almost an organism, for lack of a better word. And when we think about that, we think about drug development, we think about decision tree models. A lot of this has actually been applied in areas of pharmacology for drug development. One of the neatest things I've read recently is that there was a molecule that they found in an ancient site in Egypt, and they weren't able to identify it because it wasn't complete. And so they had AI develop a model to image this molecule, and they came up with almost 200 to 300 million possibilities. And within 6 days, the AI was able to figure out what molecule it was, and they were able to continue the excavation of what was going on. Whereas when you think about it in human speed, it would have taken us on average, they estimate about 6 years to do that. And so as we look to be able to kind of miniaturize and optimize these processes, we think about how we can apply technology that has AI built in. And the easiest thing to think about is your smartwatch on your wrist or your cell phone in your pocket. And these wearables or these intelligent devices that we carry with us at all times are monitoring vital signs, they're monitoring the environment. Your Apple Watch now can decrease the volume on its own for its headphones because it senses a high environment that may affect your ears. And so these processes are slowly being integrated into society. And I think it's important for us to look at how we can have benefit from this. And so, from an artificial intelligence standpoint, what can we benefit from, and how can this work with us? So when I think about medicine, I think about how we can augment the touch that we have with our patients, because that's never going to go away. And one of the things that we can think about immediately is, can we decrease the time to a diagnosis? If a CT scan or an echo or an X-ray can be assessed by AI and it can find patterns that may predict in the future this would be malignant or, progression of heart failure or disease modifying early on, we may be able to improve how we intervene and maybe change the way we practice medicine a little bit. We also can optimize decision making with high fidelity. And so we have a high accuracy, we have a high confidence that what we're being told by the machine learning algorithm and the systems that are being developed are going to be accurate, are going to be trustworthy, and they'll also help us with optimizing our decision paths. So maybe when you see a patient and they have a history of a cardiomyopathy, you send a genetic screening, and that genetic screening now goes under AI analysis, and it talks, to the systems that are working within the context of that AI framework. It can tell you the patient's most likely to have symptomatic arrhythmias in 3 to 5 years. And so then you follow the MRI, and maybe you don't need to put a defibrillator in somebody. And so those are the things that we can think about with how can we optimize this shared decision making. And then the biggest part in this third bullet point is really where I think AI has the largest potential to improve the way we practice medicine and the way we can transform our patients' lives, is really understanding these relationships that we don't understand, right? A lot of us in our day-to-day in transplant always talk about the voodoo of transplant medicine. And, maybe this medication will work and maybe that medication will help, or, why did they develop de novo DSAs and how come they didn't respond like my last patient? And so we found that artificial intelligence really helps us understand these unclear relationships and maybe clears them up a little bit or points us in the right direction to where we may be able to understand them a little bit better. Of course, it's going to help us connect with patients and providers in different ways. Already there are some institutions that have a big telehealth model, especially in the advent of COVID. Some of those are now moving to the next step where they have augmented reality or they have virtual reality. And so you may not be with the patient, but they see you as if you're right next to them. And so I think that's going to help us in the long run, being able to connect with patients both in rural areas in the US and even abroad. And I think the last thing that sometimes we don't think about are what are the administrative tasks that AI helps with, right? So scheduling, billing, provider management, access, and optimization. And so, wouldn't it be awesome to say, hey, I have 4 or 5 patients that I need to add into the schedule. Let's plug it into the model and see where it thinks we can fit them most efficiently without disrupting testing or follow-up appointments. And so those are ways we can think about how AI may help the patient and may help the non-clinical portions of what we do. And so when we think about AI principles, we think about improving prediction, optimizing risk assessment, but all of these are data dependent. And that's really where the bottleneck of managing patients with AI or understanding AI really sits currently. And then, of course, we talked a little bit about beyond basic AI when we talk about kind of neural networks and machine learning. And so we'll delve into that a little bit further here. And so when we talk about the traditional paradigm, we talk about lots of data, right? We always talk about big data and lots of information, but not all of that information's great. We try to do something cool with it, and then we see if it's relevant. And so we kind of just throw all of this data at a computer program and we figure out what happens. But the caveats are that it takes a very long time. The outcomes are very unpredictable, and you really can't apply that to somebody's, future prognosis or disease management. And so how can we make a clinically relevant paradigm shift? And how can we understand how AI is going to be able to change what we do as clinicians? And so again, we need lots of data, but I put an asterisk there because it's really important for us to have clean data that's very minute in its detail. And so rather than just saying you have a 45-year-old female, you say, 45-year-old Caucasian female that has this hemodynamic profile that changed over this time period with this EF and this imaging that's all banked in a way that we can access it efficiently. And then we link that data to known outcomes. So rather than now saying, here's a bunch of data that we throw at the computer and tell us what's going to happen, we tell the computer, we know that this group of patients had this outcome and this group of patients had a different outcome. And can you tell us with all of this data behind them, why that happened and how we could either intervene earlier or manage them differently to improve their outcome, right? So if somebody is an amyloid patient and we want to intervene earlier, or if somebody is a genetic cardiomyopathy patient and we want to figure out why one patient died of sudden cardiac death and why one didn't, despite both having a defibrillator, these are the ways we may be able to approach this knowing the outcome. So working backwards may allow us to actually improve our practice going forward. And then that's how we really determine these important relationships. We figure out with AI, and I'll show you some examples in a minute, on how it weighs the importance of factors that we provide to it. So maybe the traditional clinical values of GFR and time on dialysis aren't important to predict the ability for a renal graft to work. Or maybe the patient who has amyloid pre-transplant, we can use it to predict how they'll respond post-transplant from a neurohormonal standpoint. And then the other thing that's really important that changes the way it affects patients and our practice in medicine is how providers and physicians will implement that into their practice. So it's about interpretation, it's about validation, and it's about putting it into practice. And so the caveats here are, again, data quality. One of the biggest things I think that we're going to see in the next 5 years is the equity and the availability of AI and these models and services, for lack of a better word, to the general population that can't go to specialized centers that have this technology. And then can we translate what we see in a digital environment to something in the physical environment? And so I'm a visual learner. Words are great, but a picture paints 1,000 words. And so when I think about AI, we think about this traditional paradigm where we have this big data and we have a lot of that in this funnel, for example, and all of it's being churned and managed and assessed, and we have this new prediction. And then we learn from that prediction and we go back and we figure out how to refine the algorithm and we analyze this new data. And this works if you're working on Tesla software to make the car drive better, or you're working on a coffee machine to be more efficient and use less coffee but make the same amount of same flavor. But in patients, it's a little bit different. And so I think about it like this. So we have this clinically relevant paradigm where we have a clinical problem, right? So in our case, it's going to be organ failure. We have this machine learning process that we can implement, and we look at the output variables or how this is going to affect our patient or our practice. And so for our case, maybe we have patients that are going to go to transplant, are going to go to VAD, or are going to go to hospice. So we have these known outcomes where we're able to gather a lot of data on these patients, usually through the EMR or research fellows. And then we have these machine learning processes where you have different processes that are going on and they're going to give us an outcome. But the outcome in this point is not going to say this patient had heart failure. The outcome isn't going to say this patient's ejection fraction is less than 50%. It's now going to tell us these are the factors that affected the outcome of your patient. So if you're looking for all of the patients with organ failure who end up getting transplanted, why are there some patients that do well after transplant versus those that don't, right? Aside from the things you can't control, like did they take their pills, et cetera, are there other things? And so in this example, maybe they were a smoker, they had hypertension, the female gender, and the cardiac index for whatever you're studying comes to the top of the importance factors for these variables. And so how do we then apply that to the clinical practice of heart transplantation? And so I think it's really important for us to understand the different buckets where this can fall into. And so is it disease prediction, detection, and management? Is it organ recovery? Is it donor equity? Are we thinking about patients on mechanical circulatory support? Are we looking for personalized diagnostics or, genomics or proteomics or metabolomics? And then are we talking about healthcare delivery as a system? So is the way we understand AI going to change all of these factors? I think the answer is yes. I think some more than others. And I think the ability for us to understand that this change is something that will potentially benefit us is really important. And again, looking at kind of the pre-transplant patient and AI, one of the things we have to think about is when we have patients with disease, can we use artificial intelligence to obviate the need for transplant? Can we use it to help us figure out how to generate new organs from their own stem cells? Can we intervene earlier? Or maybe some patients don't follow the standard 4 pillars of GDMT for heart failure. Maybe they need pillar 3 before pillar 1. And are there some things that we can use to predict that? And so understanding kind of our diagnostic criteria of what we do for specific disease states is really important when we look at how we can apply AI, because I think it's important for everybody who's listening to this to understand that there's a paradigm shift, right? We are now at a point where some of the diagnostic criteria that we've been using for the last 15 to 20 years may be challenged with new data and new relationships that AI unearths and changes the way we maybe use VO2 cutoff for inclusion of consideration for transplant listing. Or maybe we look at pulmonary hypertension differently with reverse remodeling through to X, Y, and Z drug or X, Y, and Z support device. And so, you know, one of the things from an outside perspective is we're all transplant specialists looking to apply this to heart transplantation. But if we take a bigger view of the world and we say all of the patients that we get are at the end stage, how do we take a step back and say, let's intervene before these patients decline, before these patients progress, and before we see the speckled night sky on the amyloid echo, right? We don't want to see that anymore. We want to manage patients before they get to that process. So maybe these tools will allow us to implement them in the general cardiology clinic or in the general internal medicine office to prevent the progression of disease or refer earlier so that we can optimize them if they do need these therapies like transplant or LVAD. And then also looking at drug development, if we identify patients earlier, we now have a new substrate and a longer time period to potentially try clinical trials and optimize these patients with newer drugs that we may not have developed before. And then, of course, from symptom optimization, right? So can we predict an adverse event? Can we tell patients, hey, you're on X, Y, and Z drug. The system tells us that you're going to do better with this drug. Let's go ahead and up titrate it. Even though your vitals may not be what I'm comfortable with, or your clinical symptoms may not be as severe, we want to prevent that. And then also with wearables, now we can do remote monitoring, right? So there's technologies that are available currently that are in trial that allow us to monitor patients' blood work without sticking a needle in them, using an AI algorithm and photonics to figure out what's in their bloodstream. We can perform right heart caths by sticking a sensor on the chest and remote sending it to us without putting in a device into their pulmonary artery. And then at the end of the day, for patients in our field, thinking about transplantation, is organ recovery possible? With VADs, 20, 30 years ago, we thought about that. We worked hard for it, and some patients recovered, but we couldn't figure out why or how or who, and we didn't know when. And it would be 18 months, it could be 36 months, it could be never. And so are there ways that we can change that paradigm and look at patients from a different viewpoint where now we're not thinking about when we are going to transplant them, we're going to think about let's do all these things to improve their quality of life, recover their organ function. And then if that doesn't work, now we've given them some buffer to think about transplantation. And then can we optimize those post-transplant outcomes? And so with that kind of framework in mind, I think it's important to go through some of the examples of some of the data that we've presented and some of the research that we're working on. And so when we talk about disease detection and management, we're working on publishing this paper, but we created an AI algorithm that was able to tell us in patients that were reviewed from 1998 to 2020 with ATTR amyloid, what their risk of death or transplant is going to be. And this is interesting because we have the data and we know the outcomes. And so we have to figure out what that data means, because for the last 22 years, we've been doing things kind of the same. And so if we think about patients with different factors or different variables that may not be as significant to some of us, right? When we think about patients with amyloid and restrictive cardiomyopathy, they have an ejection fraction of 50%. We kind of optimize them, make sure they're not symptomatic, but we blame their shortness of breath and their fatigue and their, blood pressure intolerance to medical therapy on restriction. And when Dr. Nativi and I looked at this population, I just asked the question of what are the other things that we're not thinking about and how can we look at things a little bit differently? And so we looked at this with an AI model, and we had 128 patients in that model that had available testing. We had a median EF of 56%. The NT-proBNP was 1252, and their cardiac index on hemodynamic heart cath was on average 2.49. Of this group, not a lot, but 13% died or went to transplant, and we assessed this cumulative endpoint. And when we looked at this cumulative endpoint, we compared it to the Columbia staging, the NAC score, but we also looked at the individual testing to show or to help us understand, is this individual testing affecting the output of the AI model? And is it something that we need to look at a little bit further? And so when we look at it, when we look at the traditional NAC score, we got an AAC of 0.6, the Columbia staging was 0.56, cardiac index on its own predicted death or transplant at only 0.6. The VO2 max, right? So the VO2 cutoff on a cardiopulmonary exercise stress test was only 0.46. But when we took all of the clinical parameters that we had and we combined that into this AI convoluted neural network score, it actually gave us an AUC of 0.78. And so now the goal is to look prospectively, and can we use the data we have, the model we have, and apply it in a prospective fashion through some sort of a clinical trial, either randomized or non-randomized, to figure out, are we going to be able to predict when this patient's going to need transplant or death, or are they at higher risk or a lower risk? And so when you look at the nuts and bolts of this model, this is what it looks like, right? So it's a very convoluted model that has a lot of factors that put into these layers in the middle, these H layers, which are the hidden layers, the black box of AI. And they figure out a relationship that connects us to, did they get transplant or die, or did they not? And if they did, then we can figure out the weights, and we can figure out how important those variables were when we analyze that. So AI is helping us understand complex relationships. It's also creating clinically relevant endpoints, and it's improving the accuracy compared to general providers, right? So this is the model summary. When we trained the model, it had a 27% error rate in predicting incorrectly. It learned from that, and then if you look at the time, which is pretty impressive to me, it figured all that out in 2 nanoseconds and was able to tell us now with a 83% accuracy or an 82% accuracy who's going to have death or who's going to have transplant versus who wouldn't. And so when we look at this, the accuracy of incorrect predictions is 7.9%. There was just some recent literature published last year on amyloid that about 14 to 15% of referrals are incorrectly sent for amyloid when they have something else. And so if we can have that and improve our diagnostic accuracy, we may save those patients a trip, some unnecessary testing, a biopsy of their fat pad or their endomyocardium. But not only that, we can now accurately and predict who's going to have that poor outcome, and we may be able to improve the way we manage those patients as an outpatient. We may be more aggressive. We may think, hey, even though their ejection fraction is 50% and their cardiac index is really, borderline, maybe the VO2 cutoff should be changed. And so that's some of the data that we're learning, that we're working to try to get to the field to say, maybe we need to look at these different traditional parameters a little bit differently. And so, I think when we look at other patients and we look at the changes that have happened in our field since 2018, we've seen this big allocation change. We've seen a shift in organ utilization and organ optimization. We've added new technologies like organ care system or NRP, and we're going further and we're taking organs we may not have taken. And so, that puts a risk for our patients, both in receiving these temporary support devices, but also, does it give us an opportunity? Can we look at the way patients are supported now in organ transplantation with heart failure, cardiogenic shock, with end-stage cardiomyopathies? And can we recover their kidneys? Can we create algorithms that tell us about LV recovery, organ recovery, pulmonary hypertension reversal? Can we change the cutoffs for when we think patients are candidates or not for a transplant? And can we utilize those methods to understand the outcomes long-term? So long-term survival data, long-term data after predicting an event in a patient or an outcome in a patient needs to be followed so that we can validate observationally, prospectively, and in clinical practice, the model that the AI is predicting and how it looks in real life. The most important thing, though, is we need to make sure that all of the things that we do in medicine are simple, they're easily reproducible, and they're ubiquitous. So if I'm applying it in Mayo Clinic, or if somebody's applying it in Cedars Sinai or Cleveland Clinic or in the middle of nowhere, Iowa, they're still going to be able to achieve the same outcomes that we have. And so we looked at left ventricular recovery and artificial intelligence, and we said, can we utilize AI to determine which patients would recover after having an Impella 5.5 placed in the setting of cardiogenic shock? And over time, we realized, are we looking at the right criteria, right? What do we consider recovery? Is it a change in LV size? It is an improvement in ejection fraction? Is it toleration of GDMT? And is it affected by the traditional factors that we would all think of? Is it chronicity? Is it disease process? Is it age? Is it etiology? Is it male versus female? Is it the medical therapy that they were on? Is it the doses they were on? Maybe it's that some patients were placed on something earlier and some patients were placed on things later. And how is this going to change the way we think about clinical trial designs in the future? And the reason I bring this up is because when we did our AI predictive model on this, we found that our AI model was 92% accurate in predicting LV recovery within 12 days of somebody getting an Impella. And this was all based on baseline echocardiogram and an echo at 2 weeks. And when we looked at the traditional factors, we actually found that patients who had left ventricular recovery didn't really fit the traditional criteria. So gender was actually one of the least significant criteria, as you can see based on this importance plot. Right ventricular systolic pressure was not as important for RV recovery. What was most important was their baseline left ventricular and diastolic volume. And when I read that, I said, okay, well, this probably means that somebody who has a dilated ventricle with a large volume probably needs to be supported a lot longer. And so when we introduced the variable of support duration prior to organ replacement therapy, it actually comes down as device to transplant date as the second least important factor in this algorithm. And so that begs us to think, what are we missing? If patients are supported, if they're offloaded with an Impella, if they're walking around the ICU, if they're feeling better clinically, and we have clinical signs on an echo of an improvement in the left ventricular size and the geometry and the volume, why are these factors of longer duration of support or male or female gender not as significant as we thought? As you can see here, etiology of cardiomyopathy hadn't even come up. And so this led us to kind of think about things a little bit differently. And we have a very supportive collaborative group between surgeons and clinicians here. And I had a patient of mine, a personal example of mine. We had a 50-year-old female who had long-standing heart failure. She had an ischemic cardiomyopathy, had bypassed 10 years ago, and had progressive heart failure. Was on, all the good stuff, Entresto, beta blockers, MRAs, SGLT2s, but really wasn't having improvement. And so she was referred to us for a second opinion, and I ran her through our algorithm, and I thought, it just seems like it's going to be a positive outcome. The patient progressively declined, was placed on inotropes, and we brought her into the hospital. Our team decided to put the 5.5 in as a bridge to decision to kind of figure out and give us time to decide what was going on. And, when our attendings were rounding, they were noticing, hey, her suction alarms are more frequent, her MAPs are going up, and 10 days later, she's not requiring inotrope support. Her kidneys are better, her urine's better. And we put an echo probe on her, and her ejection fraction was 56%, and her pre-Impella ejection fraction was 12%. And so we thought, well, maybe this is possible, but let's think about it a little bit more. Went back to my model, and I was very confident. I said, I think she's going to do fine. I think we can explant the Impella. I don't think she's going to need transplant. And we did exactly that. We all put her on dobutamine so that we would feel comfortable doing it, but we weaned her off the Impella. We explanted the Impella. She had a background of dobutamine. We turned the dobutamine off. She stayed fine for about 7 days in the hospital. We reinstituted some GDMT, and we discharged her. And she came back to see me in clinic 3 months later after seeing multiple other providers, but her ejection fraction was remaining at 50 to 55%. And this is a lady who had an ischemic cardiomyopathy for 10 years and was going to be listed, actually was listed for transplantation. We actually made her status 7 and eventually unlisted her. She moved back home and is doing fine. And she's been about 6 to 7 months out now. And so those stories, when I see that in the science that we've done, really highlight to me that there's something that we're missing. And, maybe this tells us it's volume, but maybe that volume has to do with myocardial stretch and, the specific, myocyte types that she has and the genes that are in those myocytes and the sarcoplasmic reticulum and how it responds to calcium stabilization. And so those are kind of the next steps when I think about where we are and where we can go, is I think that understanding this gives us a little bit window into what we really don't know. And to when I talk to my fellows and other residents, I say, AI is great, but it's kind of like thinking you know everything that's in the ocean, and then you put your head under the surface and you have no idea what just swam by you. And so I think that's really important for us to understand that we have these tools that are available, and the larger data we get, the more applications that we can develop, maybe help us point us in the right direction. And I think one of the biggest things that I see in the future is when we talk about transplantation is donor allocation. And, a lot of patients now are agreeable to DCD donation, which is fantastic and improves our opportunity to procure more organs. But the biggest problem we have is, cardiologists and surgeons are being expected to figure out how we donate. And one of my colleagues, Dr. Lyle here, was, brave enough to write this wonderful letter, and it was in JHLT this year, talking about the current scoring systems, that we use can help us figure out maybe when patients expire, but they don't incorporate neurological examination and they don't incorporate imaging. And so when we kind of look at this bubble, right, that starts with the neuro exam, the spontaneous breathing trial, the CT of the head, the patient's history, the age of the patient, the cause of death of the patient, other family factors, et cetera, we realize that, the layers of the onion are quite deep. And we really don't understand, especially in DCD donation, who's going to expire and who's not, and how we can do it well. And one of the things that is difficult for me to process is the inability for us to be able to use organs that would be usable, because we can't figure this out. It's an emotional thing for us. It's difficult for the patient's families. It's also difficult for the recipient when you tell them, hey, well, unfortunately that organ is not going to be transplanted in you today, and they have to sit there and wait, or they have to go back home. And so I think we're looking at DCD donation in the liver population, because that's a large group that's been doing it for a while, and using their data and trying to figure out how we can actually optimize potential algorithms to predict DCD expiration or organ utilization. And I think that, these are the areas where, as we start to grow as a field, as more people are involved, we start to have these ideas and these collaborations. We're working with the greats in Mayo Rochester that develop scores to predict neurological, demise, and we're adding our transplant and AI flair to it. And so I think as we walk through kind of the pre-transplant patient, the intra peri-transplant donor selection, recipient optimization, those are all opportunities to improve on. And then post-transplant, we have a lot of opportunity where we can use artificial intelligence to help us understand how we can find low-risk patients, high-risk patients, but also how we can optimize the outcome of our patients. And so, again, how can we use our current methods to understand outcomes, and how can we make it simple, easy, reproducible, and ubiquitous? And Mayo Clinic in Rochester has done a lot of groundbreaking work with the 12-lead EKG and using it to understand ejection fraction, amyloid risk, et cetera. And one of the things that we decided to look at was, one of the parts of that prediction is the EKG at Mayo can actually tell you the age of the patient. So there's the physiologic age, and then there's the chronologic age. And we all do this innately, right? You walk into a patient's room and you say, wow, that's a 60-year-old that definitely doesn't look 60. And that could be a bad thing, that could be a good thing. And so when we look at our AI system, this is kind of what it looks like, where we have these EKGs that were done for this patient. And the third from the right column shows you that you have the real age. This is a 27-year-old person, and it tells you their ECG, or their physiologic age. And so when I started seeing this, I started thinking to myself, well, if somebody's 20 on the outside but 60 on the inside, what happens to them when we put in a 20-year-old heart? Do they now become 20? Do they stay 40? Are they 60? Where are they going to be? And how do we use that? And does that improve or change the way we manage these patients? And so when we looked at it, we found that this was what was happening. So the blue box is our recipients in this cohort that we'll talk about, and the orange box is the AI EKG heart age. And so in general, the median age was about 10 years above our recipients' age on the EKG at the time of transplantation, which meant to us meant that they're probably much sicker than we assumed. And that was evidenced by them obviously needing a transplant. And so we looked at, physiologic age versus chronologic age. We looked at donor age and recipient age. And what we found is that in this matched group of 65 patients that were transplanted, donors and recipients, we saw that the donors were significantly younger, which we would expect. Male and female were fairly even between the donor and the recipient, and there was some gender mismatch. And so the question is now, when we look at the age distribution, what happens at the time of the patient getting an EKG and using AI to predict their age? And so at our practice, what we do is we have the blue, which is the donor distribution. So those are all the donors. They're obviously younger. The gray is the recipient distribution. So they're obviously older. And then the red that you see is what the AI told us the patient's age was at discharge after transplantation. And so there was a youngward shift or a downward shift to younger age after transplantation in all of our recipients in this cohort. And the question was, how does that affect their short and their long-term outcome? And so we followed them for a year. All of our patients at a year get their yearly annuals. They get an EKG, they get an echo, they get all this testing. And we actually found that it's separated into three different groups. That patients that were overlapping. So if you see here, patients that were overlapping from the red into the gray. So their discharge AI EKG age, let's say, was 50. Their true age was 60, and so they're kind of overlapping on their curve. If they overlapped within 7 years, we actually found that long term they had an increased risk of having rejection. And so if they didn't become younger enough after transplant, we felt that there was some sort of a physiologic inflammatory process or some underlying milieu that kept them at a higher risk category for potential rejection at 1 year. And when we looked at those patients that were younger, more than 7 years from their original transplant physiologic age, we found that those patients had less rejection. And we looked at biopsy, we looked at donor-specific antibodies, and then because we followed them for a year, we also looked at vasculopathy development. And there was some trend in patients that were older after transplant, despite receiving a young donor, that they trended to have a higher incidence of vasculopathy early on. And so we're working to figure out what those relationships are. What is it? Is it, the risk of CMV? Is it the EBV? Is it donor profile? Is it time from, procurement to implantation? Is it method of procurement? Is it pre-transplant status? And, the traditional factors and the traditional things that you would think would come up to the surface, like smoking history of longstanding heart disease, really actually didn't come up in our analysis. And so we're still parsing that data and trying to figure out how we can use a 12-lead EKG that's non-invasive, that allows us to predict a 1-year outcome with AI and really understand that. And I think one of our colleagues here has worked hard to kind of correlate the EKG to the biopsy and predict rejection. Which I think is fantastic, but I think the long-term outcome would be awesome to say, we don't have to do as many biopsies. We don't have to run your ProGraph as high. We're going to protect your kidneys. We're going to reduce your risk of infection because your AI ECG age tells us that you're a low-risk patient, and now we're going to follow you on that pathway. Versus if you're a higher-risk patient, maybe we correlate that with more cell-free DNA testing or, more biopsies early on, or we watch them for infection closer. And so being able to kind of determine that is really interesting. And some of our data shows that may be the way to move forward. So that's just kind of one example of something we've done here. Another project that our team is working on, a multidisciplinary team with our dermatologists actually, is to figure out, the number one long-term killer is cancer. And so how do we reduce those skin cancers that are causing our patients issues without having the biggest issue for dermatology clinic here has been access, and I'm sure you guys see that too. And so one of the projects that we worked on is to figure out, how we can optimize skin cancer detection without having the patient be seen. And so we all, 90% of us probably have a smartphone. And so we figured, well, let's take a picture. Let's look at the lesion. Let's compare it to lesions that we know about from our massive pathological database that most hospitals have. Let's train the algorithm. Let's tell it what's going on. And then it's going to know the difference between a malignant cancer and a benign cancer from an image standpoint, and also that image correlates to a pathologic diagnosis from a path slide on that patient. And then we tested that and we said, what's the unlabeled data and how can we figure out who's going to be a malignant lesion and who's going to be a benign lesion? These patients were obviously being followed by a dermatologist, but they were using this to track the results on the post-Mohs biopsy result. And the correlation rate for the study that was conducted was 97%. And so patients had a very high correlation with their image being able to predict the pathology. And so being able to, take your transplanted patient who, was in Florida for their transplant, stayed there 3 months, and now moved back to, Ohio or California or Nebraska, and, having them being able to do a virtual dermatologic exam, being able to send that data to you, have your system process it, give you a result that says, hey, this patient's high risk, and then either having them come in or be seen locally and being able to manage that care. And so I think these systems are in development. Some of these are currently available in some sort of a commercial process, but not fully. And so I think, when we think about the pre-transplant optimization, the peri-operative donor optimization, and patient optimization, and then the post-transplant, survival, infection, and cancer risk, we really have a lot of avenues to intervene on. And I think it's a really exciting time, and I'm super excited about it. The one thing and the hope that I have is that we can give access to all of our patients. And so I always take everything with a little bit of grain of salt and try to make sure that when we're doing something, we're doing it in a way that's going to be equitable, it's going to have a positive impact, and it's going to be accessible. And so I think this was a fantastic article that was written in the Journal of General Internal Medicine a couple of years ago, and really talks about how we can, enable these processes, optimize patients, change the way medicine affects our patients and maybe other patients that we see as well, but also changes the way we interact with patients and we interact with the data that we're receiving. And so, I think having a patient come in and drawing their blood and kind of giving them a report is really not the long-term method for the way medicine will work in the future. I think it'll be more of a conversation with, data being submitted by the patient, by their wearable, by their blood work, by the AI system. And then the physician or the provider who's seeing that patient's job is going to be that they need to synthesize that and they need to be able to improve that outcome and or intervene earlier or provide that expertise. And, this drug is better than that drug. And then all of this under the, on top of that foundation of how can we improve cost, how can we improve access, and how can we make sure that patients are being able to access this in an equitable fashion. So, I think it's really exciting, but I also think we need to balance it off by how we can get it to patients that need it and do that in a way that's fair. And lastly, I think, one of the things is how will we change the way, our interaction with patients goes. In my clinic now, a lot of times I talk with them about some clinical trials that we're enrolling with that will, obviate the need for blood tests. And so, if we have a smartwatch on a patient and I need to check their blood work, for NT-proBNP or their CBC or their renal profile, having those conversations where being able to integrate this technology is going to change the way we discuss things with patients and the way patients interact with us, because some of these things, when they become commercial, kind of come to the masses, and the patient will take a picture of some sort of device that they saw on TikTok or wherever and say, how come you can't implant this in me? Or how come you haven't given me this drug? There's this report that shows this. And now with ChatGPT being able to pass all these medical exams, I think everybody's going to apply for medical school. So there's lots of stuff coming, but I think it's important to understand where we can balance it, how we can make an impact. And then in review, I think, as I've hopefully described and you've seen, that it's it's a field in evolution. There are some clinical ready applications that are going through FDA validation that we've been a part of and that others have been a part of that are going to change the way we practice and the way we intervene and manage patients. But I think, again, the focus should remain on being simple, being reproducible, and being accessible. And all of this is probably going to some way impact how we practice and manage patients. And I always come back to the phrase of how we can use artificial intelligence to augment our human touch, right? Because being able to put a stethoscope on somebody or hold somebody's hand when you have to deliver good or bad news is nothing that AI will ever be able to replace. And I think being able to empower what we do to help the patient build trust in the healthcare system, build trust in these technologies, by you attending this is really what's going to make that big difference. So that's my last slide. I think we're going to go to some questions, and I'll turn it back over to John.
Thank you so much, Rohan. A great talk, really very stimulating. And I tell you, you bring up more questions than not over time here. We have, let me just start off with a question that I think one of the listeners also had brought up, and that's about AI being generalizable, mainly because there's some publications that describe intrinsic racial bias in artificial intelligence. And what have we done, or what are we going to do to address these intrinsic biases in the application of AI in transplantation?
Yeah, no, that's a fantastic question, and I'm thanks for who is asking it. Thanks for bringing it up. I think one of the biggest things that I feel is a hindrance in how we use artificial intelligence is the quality of the data that we get. And unfortunately, based on just kind of the way our society works, the way we have the ability to capture data, it's never that clean. I was looking at doing an AI study with the UNOS database, and there's 300 variables and 70,000 patients, but if you look at it and drill it down, maybe only about 10,000 patients have that data that you need that's reliable and that's generalizable. And so from a bias standpoint, I think that the racial bias has come about because I think access to healthcare has been difficult in certain populations, and they may not have been able to participate in some of these data gathering studies or be part of these databases. And so we have an innate bias to address there. I think the generalizability of AI is more in the question that you're asking and the data that you're gathering. And so, when I was at ISHLT, one of the questions that Dr. Uriel asked me from Columbia was, you have a really good AUC on your TTR. Everybody here else is presenting with AUCs that are the same as linear regression models. So how did your AUC get better than everybody else's when you have the smallest population? And my answer to him was very simple. It was in the quality of the data that we're getting, because you're able to go to such a granular level that you can trust that the input that you give and the outcome that you have are reliable and reproducible. And so I think in order to address that innate bias from a racial standpoint, from a societal standpoint, from a socioeconomic standpoint, access is huge, and being able to have access to patients to be part of these databases or part of these data gathering efforts is really what's going to help us make that paradigm shift.
Great, thank you for that great response. One of the things that has also been brought up is, we used traditional statistics, in terms of taking a look at older donors and, left ventricular ejection fraction of the donors. How much more effective is machine learning compared to the traditional stats that we use? Are we going to get a lot more bang for the buck using machine learning in terms of, let's say, donor selection?
Yeah, that's a great question. So, a lot of programs have adopted the predicted heart mass index. And so when we look at the PHM, we actually didn't use that for a while. We've adopted it over the last number of years, as many centers. And one of the things that we found is that when we compare our prior data, one of the things that we used to look at was aortic root matching. And aortic root sizes from male to female, may be different, PHM may be different. But when we look at the AI process of donor selection, those aren't the things that come to the top. The things that come to the top are usually, what was the initial pH of the patient? How long was that pH below 7.4? How long did it take for the systolic to stay, above 200? Or how long was the systolic below 90? And so I think that some of the things that you and I and others on this meeting are looking at are the traditional factors. And when we apply things that are not traditional, such as, the age of the person, the distance that they're going to be, if they're DCD or not, are they, what's their alveolar wall thickness, we find that things that we weren't predicting would be important are coming to the surface. And so I think it's important, just like Kidney did with the KDPI, we need to work towards figuring out how we can look at organ optimization and procurement with some of these new methods. Now, is it going to change it to where we go from 3,000 a year to 5,000 a year? I don't think so. But I think in those patients who are a status 1 on ECMO, when you get a donor who just got hit by a car and they have chest trauma, and the PHM is borderline, it may allow you to say, hey, you know what, I have some more confidence and I'm going to be able to take this organ.
Great response. You mentioned also that, there's data that is not being used, data that is not really been used in terms of placing into algorithms or to equations. Donor management goals.
Yep.
Darren Malinowski has done some great work in Oregon and has looked at the DMGs and actually find that they do impact outcome as well. Have you, looked into any of these donor management goals? Because
Yeah.
donor management may be a lot more of a concern than we think.
Exactly. And so that's kind of what I was alluding to. So we haven't looked at it specifically yet. That's one of our projects on our whiteboard. But one of the things is exactly what you pointed out, right? Is when an offer is made and how long the hemoglobin is below 8, or how long the oxygen saturation is less than 60%, or 50%, right? So the part of AI that I like that with those tables and with those importance values not only tells you, what's the important value, or sorry, what's the important variable, right? Let's take oxygenation, for example. But it will be able to eventually, at some level, give you a percentage cutoff, right? So maybe we think that 50% oxygenation is great, but the AI says, hey, actually, 62% would be greater for most donors. And so then we have a new target to look at. So I think it helps us with donor management goals in the fact that maybe, we're shooting for a map of 60 to 80, but maybe a map of 50 to 70 is a little bit better. And those are the things we don't know yet. And so I think traditionally it challenges us to say, can we be comfortable in redefining some of these management points? But at the same time, being able to gather that data and then look retrospectively, knowing the outcome, was that organ utilized, was it not utilized, may allow us to fine tune that some more.
Great. One of the things that is being used right now is the kidney eye box. You may be familiar with that, using AI to predict outcomes, to predict clinical trial outcomes.
Right.
And that's something that the FDA is looking into.
Right.
What are your thoughts about using this type of AI to predict outcomes in clinical trials, which could actually increase clinical trials, because instead of going for 5 years, you're done at 1 or 2 years and use AI to predict the rest. So what are
Yeah,
your
so
thoughts?
yeah, that's a great question. I don't think, if I were to be completely honest, I don't think we have enough information in large scale trials right now to be able to make those kind of long-term predictions. I think the shorter term prediction that you make with the ability to improve the quality of the data that you're looking at is what's going to drive those long-term outcomes. So for example, I think it would be fantastic, and we're working on doing it here, is everybody that has an ECG, we follow them after transplant and we look at their 5-year outcome. And then we do a clinical trial where we change the paradigm of managing these patients. So if I have an EKG and my EKG age says I'm low risk, I no longer get biopsies. I no longer have to worry about certain prograph levels. I no longer worry about frequent follow-up. And then we look at the outcomes. And anecdotally, on some of the patients that we've had to do this with, because they have travel issues, or they've had, with COVID now, patients are out of the hospital for 20 days or 30 days and they miss these biopsies. We've seen that some of these lower risk patients actually do just fine. And so, I think when we think about clinical trial data, I think the important thing to look at is, one, are the variables that are being looked at from a clinical trial standpoint for an endpoint valid? And two, if not, how can we use AI to help us guide to maybe looking at a different endpoint, right? And maybe that's where the AI is going to be useful in the clinical trial, not looking at the long-term outcome, but really looking at the endpoint, and are we getting it right?
That's outstanding. Yeah, we we all look to see what are the real critical endpoints, and
Hmm.
certainly 1 year survival is not making that
Right,
happen per se.
right.
Final question that I have from one of our audiences. As AI becomes the norm in healthcare, do you think that the variability in practice and treatment will become less? And with less variability, will there be a glass ceiling in AI learning that will prevent us from continuing to test new waters or
Yeah.
push the envelope?
Yeah, so I think that's a great question. So I think it's a two-part answer. So one, on the first hand of, is there going to be less variability? I hope so. I think there may be changes in the way we assess patients earlier on, and maybe there's less hesitancy to refer to an advanced provider earlier on. And two, I don't think there will be a glass ceiling. And the reason for that is a lot of the stuff that we do in the AI world actually doesn't occur in real time. We have what's called this digital twin. So we have exactly what's happening in the ICU or in the real world mirrored in a sandbox that can't affect anybody. But we can test all of these different permutations of medical therapy or follow-up or what have you, and then look at how that response changes the outcome of that patient, and then try to work on that in the real world. So I think our ability to evolve and grow and develop these technologies is not infinite, but pretty close. I think that there's an asymptote we're going to reach at one point, but for right now, we're able to replicate that in the digital world and do it in a way that has reproducibility.
No, you're absolutely right. That digital twin idea is certainly something that is virtual and
Yep.
something that can actually be tested and become real in
Yep.
long term. So yeah, no,
Yep.
that's fantastic. Listen, Ron, this has been great. I mean, I think we could
Thank
ask you questions all day long, and certainly you have enlightened us on what AI and machine learning is all about. So thank you for all of that. Now, with that in
Absolutely.
mind, I'd like to thank Dr. Goswami for his great talk. And let me please hand this webinar back over to Brian. Please, Brian.
Thank you so much. AST would like to thank Drs. Goswami and Kobashigawa, the leadership of TxAQM COP and TCC COP, and all of our attendees for today's excellent session. Please look for an email from Zoom in about a week directing you to a copy of the recording available free and on demand. Finally, please remember to complete the evaluation survey in Zoom and visit myast.org/education to learn more and register for our upcoming webinars. Thank you all again for today's excellent session.
Thanks, everybody. Have a great day.